from you folks.
Are people in this province, just to put a fine point on, are people in this province actually dying because they're not able to access the services, the health services they need? I guess that's what people would like to know. You're on the front line, all of you.
I would say that people are waiting too long, not only for emergency medicine services, but for all their important services. And it is negatively impacting their health. If we don't have primary care physicians to support emergency services, then the emergency services becomes the fail-safe. And you cannot keep adding layers and layers to that singular service. It just cannot handle the volume. And even if it could handle the volume, it's not handling the volume in an adequate way. We are not primary care physicians per se. That is an important cog in medicine, and it's what needs to be advocated so that those patients never show up in emergency departments. Because if their illness is allowed to escalate because they can't get in to whatever service that's required, then they land on our doorsteps. And they should never have been landed on our doorsteps in many respects, because they should have had those basic needs dealt with long before we ever said hello to them. And when they do show up on our doorsteps, if we don't have the adequate and properly trained people to take care of them, then yes, negative outcomes can happen. So, and the only way you can be saying we have the properly trained, adequate persons in our departments is to be able to recruit those people. And the recruitment requires an economic package. You can't avoid it. I mean, you can talk about the weather and the scenery and the wonderful people and everything else, but at the end of the day, you have to also include the economic part of it. And that's why we're here today.
Dr. Estelle, you mentioned an example in Labrador West where a gentleman had a negative outcome, and it doesn't get much more negative than dying.
No, it's sad and it's unfortunate. And as I stated in my presentation, this is with family permission. Obtaining the services of a CT scanner and other appropriate questions and equipment as you were talking about, I mean, that's not, I mean, we are below the standard of care with regard to infrastructure further than we should be, and it's just unacceptable. And you know, it makes it's extremely hazardous and dangerous for the patients, especially where we're so geographically isolated that we're often required to stabilize and maintain these patients for longer periods of time. It's unacceptable.
What are your views on moving the air ambulance from St. Anthony to Happy Valley Goose Bay?
It's unfortunate that one centre in our province loses while another centre appears to have gained. Difficult decisions to make. I'm firm belief that there always should have been an air ambulance service in the Labrador section of our province, and undoubtedly serious look needs to be looking at acquiring a third air ambulance.
I'm looking at all of you who are born and bred in this place, and there's constantly talk about recruiting and retaining people who are from here. I guess the question is, though, if it is really so bad, why do any of you stay?
Well, I've trained at Memorial. My family roots are in Eastern Canada. I've come back and been trying to improve the quality of a tertiary medicine in this province for 7 years, and I still feel that we have lots of areas to improve upon, and we have the energetic people to do it. But we are getting to the limit of what the cadre of people that we have in the system can do. And the demand on the emergency services is growing, and we need to grow with it. And I am here more than willing to stay in this province to the end of my career, as long as I know that we're continuing to add to the demand that the citizens require. And as I've said, we want not only just to, in the tertiary sense, to be isolated within the walls of St. John's. We want to bring that expertise throughout the province and start improving the quality of care that's delivered out there by helping out the physicians with continuing medical education and things of that nature. So there is still a desire to move things forward because we've seen movement for the past number of years. If there was zero movement and things were moving backwards, then I would hazard a guess that many of the skilled people that we've brought into this province won't stay.
Sure. I am a MUN graduate, but after 8 years of university and 2 years of my residency training, when I finished in 1997, the wage that was offered to me to begin my practice wasn't enough for me to be able to pay off my 10 years of student loans and take care of my family. So in 1997, I moved to the United States, and I did not return until 2006. And I didn't return for financial reasons. I returned because this is my home and my family is here. It would be nice to be able to pull a lot more expatriates back because they're able to practice here, but I moved because I wasn't able to practice here.
I'm been here for 20 years myself, and Newfoundlander, and my roots and my family are here. When I first went to Corner Brook, I'm an orthopedic surgeon. There wasn't any teaching or anything there, so I worked hard with the university to have students come regularly, and we built up an excellent teaching program. And you can ask any student that's gone out there about the rewarding experience that they've had. For me, that is part of the drawing card, my family, that sort of thing. I'm from Newfoundland. But those are the major features that you'll find from a lot of people who do want to stay. It's been challenging, but again, we accept that. And our only goal is to improve patient care. And unless those of us who really believe into it stay here to make it work, it's not going to work. And we have to get the cooperation of all the players. And if everyone's not going to try to help each other out, healthcare here in Newfoundland and Labrador in the future is going to be very dismal. And again, as I said before, we're looking for a plan for the next 10 years, not for the next 2 or 3 years, for 10 years, so we can recruit people and we can get qualified individuals and we can provide the better care for our patients that they deserve.
Dr. Costello, how many times in a 2-week period would you work one of those 24-hour shifts?
We would do six 24-hour shifts a month. Now, what often happens, I didn't get into the logistics of all, there are situations, like for example, I have my call schedule for May. So in the first 12 days of May, I will do 5 24-hour shifts. Because physicians are going on leave, physicians are attending CME, physicians will be out of town. That leaves less time in my clinic, more time in the emergency department. You have to adjust yourself accordingly because, as I said in my report, it can be physically demanding, it can be exhausting. But physicians aren't jumping out of boxes to move there. Our numbers are low. We're having major difficulty recruiting, and we're trying to do the best with what we have.
Right. So what kind of a break would you get following that? Would you get at least 2 days to unwind and?
You'll get at least 24 hours, maybe 48. It depends on the scheduling. We have a physician there, one of our senior physicians, who likes to do 48 hours. All right. Now, you may get lucky, you may get some sleep during that 48 hours, or you may be living in the case room or in the OR or continuously in the emerge. You have to watch out for emotional stress, for physical stress. Your guard can get down, you can become weakened, you can start making mistakes, patients can suffer, physicians can suffer. And this should not. The situation should not be present so that this type of situation can happen.